let's say, gets neoadjuvant T-DXd, according to DB11, but has residual disease, are you going to give him TDM1 or are you going to give him more T-DXd?
This is a great question. So I think that with the release of both data sets at once, this is the situation that we're in now. If we're using T-DXd in the neoadjuvant setting, what do we do for residual disease in the adjuvant setting? I think the way that I view this is that there are certainly questions here, and one is that is the residual disease an artifact of needing more exposure to T-DXd? Is it due to resistance? So I think some factors will come into play in that decision in terms of how much residual disease are we dealing with, what type of treatment response did we see. I think in the setting where I suspect that we're dealing with resistance, if it's a suboptimal response, which wasn't the case in the majority of patients in the trial, but
sure.
if that is the situation, then I would think about using a different agent.
Right.
But I suspect, based on what we saw in the trial, the response rates and so forth, in both trials, that it might be a matter of needing more exposure to T-DXd. And so we do have the option of continuing T-DXd pending approval, of course, in the residual disease setting, even if we've used it in the neoadjuvant setting as well.
Indeed, the residual cancer burden scores in the trial, RCB, the 0-1s were like over 80% in the T-DXd. That's the highest I've ever seen.
It was really quite remarkable.
And I believe this trial, the DB11 trial, like sets a record on that front.
Yes.
Doesn't it?
Yeah, absolutely.
Amazing. Yeah. Good. So you think both of these potentially are practice changing?
I think so, yes. I think this is, the data are encouraging, and as we've been discussing, the AE profile is also encouraging. And this is a high-risk population, and so we really need to advance our treatment approach and our cure rates in the primary setting, and T-DXd has done that in these trials.